Okay. Anemia or low hemoglobin is not actually a diagnosis. It is only a symptom. So the definition wise, what we can tell is that level of hemoglobin. If it is less than 120 among females, or in males it is 130, and if it comes to pregnancy, it's 110, and you know about children, it's varying with the age. So, what do you think about the number of people who are suffering from this anemia or low hemoglobin in the world? Is it 1 million or 2 billion? Uh, I will give you the answer in due course. So, the what is the problem with anemia if you have low hemoglobin? So the productivity will be going down because of the low delivery of oxygen and the poor cognition and physical status. And also there are other mobility and mortality issues when it comes to maternal mortality, stillbirths and maternal mortality, low birth rate, etc. And also when it comes to pregnant females, the most important thing is postpartum hemorrhage. You can have more and even have you can end up in death. So in the world, if you have a look at the prevalence, the most prevalent among the Southeast Asia and also African countries when it comes to the whole world. And the what is the impact? So in the global population, it's about 2 billion people are affected with this. Hence. So especially the female and preschool children, uh, 89% of all these cases are in low and middle income countries. So in Asia and West Africa. So out of these anemic patients, 60% of those are due to iron deficiency. So how do you get this anemia? It's either poor production due to lack of uh, raw material to produce hemoglobin or the production of hemoglobin or the red cell, or increased loss of red cells or broken down red cells. And also in conditions like pregnancy, you can have high demand or the dilution is another thing. So it is not only that, there are various other determinants that you will encounter when it comes to anemia. So it could be either due to political, economical, or ecological reasons, or climate reasons, or geography. So these are other things that we have to consider. And also there are some underlying determinants such as uh, age of childbearing and short birth spacing. So those are very important things to consider when it comes to this topic. And also other determinants like intermediate, like food insecurities, like quality and quantity of the food what you consume, and also poor maternal and child care, and also health, nutrition, and other interventions, inability to access those, and inadequate knowledge about the health, nutrition, and also poor education about the nutrition. So those are very important. Apart from that, the other thing is the sanitation. If you don't have good sanitation, that is also another issue. So pure intake, absorption, utilization, chronic diseases, and poor response to infection diseases are the other things. And altogether, the outcome will be with the genetic and hemoglobin disorders, you can end up in anemia. And also, whatever the condition you get, the management part comprised of all these factors. Number one, it is the history. You have to take a proper comprehensive history when it comes to the case, and also examination properly, investigation, laboratory investigations and treatment, and other management like treating underlying issues. So when it comes to the history, the most important uh, facts that we have to elicit are history of bleeding and also dietary components, especially when it comes to diet, whether we are consuming enough iron containing and vitamin containing food, and also other GI issues, such as in UK, there are bigger problems when it comes to gastric bypasses and other uh, related iron deficiencies and B12 deficiencies, and also the medical history when it comes to chronic infections such as TB, pulmonary abscesses, and especially kidney diseases are very common among these group of diseases. And also chronic inflammatory other infections and conditions like SLE. And also the family history is very important. I'm sorry about the last line. Other hematology diseases, uh, such as uh, bone marrow issues, especially when it comes to bone marrow and hematological issues, you have to ask about the B symptoms. Means whether you have any recent loss of weight, loss of appetite, or any night sweating. And those are very important factors in the history. So the history will be going towards that the details, signs and symptoms, whether they are present, uh, how quickly they are progressed, uh, whether it is if it is a bleeding thing, then you will have very sudden or quick progression of the issue. And if it is a slow progressing one, then it could be very well due to deficiencies such as hematinics, iron or folate or B12. And also the age of the patient is very important. Younger will tolerate very well, but when it comes to the elderly and debilitated, it's not easy to tolerate. And also other cardiac or and respiratory symptoms are also important. And now it's when it comes to general examinations, examination of the general things like lymphadenopathies and leg ulcers, and also cardiovascular signs, and also the lung signs like added lung count. And abdominal examination is very important when it comes to hematology, because you can have hepatosplenomegaly. I'm sure you know what these things are when it comes to examination. Uh, the basic investigations we should go through are the full blood count and the blood film. And rest of the things, the hematinic and other hemolytic screens, depending on how the history is directed. And the biochemical investigations are very important to see how the renal and liver functions, and CRP can be guided to see whether the ferritin level is true. Right. When it comes to the full blood count, the most important thing is MCV as well as the hemoglobin level. The, in simple words, you have low MCV means microcytic anemia, and high MCV macrocytic anemia, and normal MCV normocytic anemia. So microcytic anemia can be due to most probably iron deficiency and also other causes I will explain. And high MCV means B12 folate or MDS and alcohol, etc. So when we consider the MCV levels, the microcytic anemia serum, if you see this serum iron studies, and if the iron studies shows that low iron and ferritin with high total iron binding capacity, then it is definitely iron deficiency anemia. But if it is low or normal iron and ferritin is low, uh, normal ferritin, then it suggests a component of anemia of chronic disease. That's very important stuff. Uh, Sometimes you will have it with iron deficiency anemia also. Mm. And if it is MCV level normal, 80 to 100, Then you have normocytic anemia. Reticulocyte count is very important. And if the reticulocyte is less than 2%, it can be due to leukemias, aplastic anemia, pure red cell aplasias, and other marrow failure syndromes. And if the hyperproliferative sort of picture, then it could be due to very well due to hemorrhage or either hemolysis is the cause of anemia. If the MCV level is more than 100 than a macrocytic picture, then macrocytic anemia, uh, then you can see the neutrophils, how they are segmentation. If the segmentation is high, with the blood film only, you can see that it could be very well due to B12 and folate deficiency or drug induced. If those are absent, then it could be due to alcohol abuse or MDS. Very important that you cannot miss these things. Microcytic anemia, iron deficiency. Normocytic anemia, myeloma, you can't miss that. And also macrocytic anemia, B12 folate, PSH, and reticulocytes are important. Those are the salient things when it comes to this. When we talk further about this microcytic anemias, blood film will be showing hypochromic microcytic picture with pencil cells and targets, etc. And also, a very important thing in iron deficiency is the hepcidin level, which is the gatekeeper. So when the gatekeeper is there, when hepcidin is high, the entrance of the iron into the body will be reduced. When hepcidin goes down, the entry of the iron into the body will be going up. So those are few things to understand. And also, if the most important thing in this picture is this the last one, if it is a functional iron deficiency, and if you don't diagnose that well and give more and more iron to the patient, it can end up with excess iron, and patient can have iron overload and also organ damages and end organ failures even. So that's very important point to remember. Right. So thalassemia is another important factor in our country also, in Sri Lanka. So you will have anisotropic pinocytosis and some nucleated red blood cells, etc. And the cellulose acetate uh, uh, hemoglobin electrophoresis will give the proper understanding. There are further investigations to be done when there is a microcytic anemia. So the important tests are fit testing. I don't know whether you are familiar here. So fecal immunochemical testing to see the bleeding bowel, and also endoscopy examinations are very important. Hemoglobin electrophoresis and Helicobacter pylori testing, and immunoglobulin and colonoscopies and gin, as we had the Kirana explained the previous in previous lecture about the gynecological issues. Or in addition that, we have to look into the fact that whether there are any bleeding issues, von Willebrand disease, bone marrow examination, and iron hematology referral, iron staining, etc. And also hematology referral will have to be considered if all those are, if you find accordingly. The flow cytometry for CD55 and 59 will be another thing to diagnose PNH. And also other investigations, as Kirana mentioned, ultrasound examination. So all in all, this is an important thing when it comes to anemia of chronic disease with iron deficiency. Classification of macrocytic anemia, when we see whether the MCV level is more than 100 femtoliter, then vitamin B12 and folate has to be examined. And also liver disease and myxedema are to be eliminated. And cytotoxic drug intake is another thing, and we should not forget about the pregnancy. And the MDS is very important thing to remember. And the other thing is the blood film. Blood film will show macrocytic picture, especially oval macrocytes, and some of the neutrophils will have these hypertrophic. Sorry. Right. So further investigations for the macrocytic anemia, B12 folate level, liver function, intrinsic factor antibody is another important thing, and gastric parietal cell antibody will be another thing, and TSH also. So when we come for the classification of normocytic anemia and normochromic, it is 80 to 95 hemtoliter size cells, and you will have these hemolytic anemias and also other conditions like renal disease and mixed deficiencies, etc. So hemolytic anemias means that your red cells are broken down very easily in the intravascular compartment, or maybe it is in the liver or spleen. So lifespan will be shortened to around 30 days. What is the normal lifespan of the red cell? 120. Yeah, very good. So intracorpuscular and intrinsic defects are the important things, and also extracorpuscular. And hemolysis can be due to either intracorpuscular if there are membrane issues, metabolic defects like G6PD and pyruvate kinase deficiency, etc., and even thalassemia and sickle cell. And extracorpuscular issues will be there due to immune or either non-immune causes. If it is immune, it could be due to a warm autoimmune or cold autoimmune condition. And non-immune causes are like malaria and chemical and things like PNH. So there are lots of spherocytes will be seen in the peripheral blood. In G6PD, you will see this white cells. I'm sorry, I can't. Yeah. Yeah, it's somewhere here. White cells. And also, and the other thing is the microangiopathic hemolytic anemias. You will see fragmented cells, right? Evidence of hemolysis is very important. You have to do the hemolytic screen, DAT, hemoglobin, haptoglobin, plasma hemoglobin, haptoglobin, and elevated LDH, etc. So the further investigations wise, evidence of erythropoiesis is very important. How is the production? By doing the polychromatic blood film and see polychromasia, and also reticulocyte count is very important to see how the production is, and also cellular bone marrow hypercellularity. And the further investigations wise, morphological evidences for the damaged cells, osmotic fragility testing, and specific enzyme and protein testing can be done. Sorry about the busy slide. Other tests consider hepatitis serology and monospot testing, malaria film, thyroid function, ANA, rheumatoid factor serum, creatinine, kinase, and erythropoietin levels are also very important when you investigate anemia case. The management, pretty simple, treat the cause. So if you treat the cause, you will end up with the issue. But there are no places for blood transfusions in anemia. The important thing is to damage control, either GI bleed or GU bleed or review of medications, etc. And NSAID is used. The second thing is to replace whatever lacking, B12 or either folate, or maybe it is iron. When it comes to iron, it is done with either oral, or if oral is not effective, then you will have to go for IV, especially these GI issues. As I told you, in UK, there are so many patients with GI bypass, gastric bypass surgery. So they frequently come with these iron deficiencies. They need frequent IV iron infusion, especially either monofer, osmofer, or inject, depending on how the allergic situation. And the dietary advice is very important. What is to take, what is not to take, and when to take. When you take iron tablets, especially, it's better to take it into the empty stomach with some lime, lemon, or orange juices. and not to take tea or coffee or dairy products with that. So those are a few important tips for the patients. Uh, so if there is any issue in the IV iron need, I think it has to be done in a hospital setup. I don't know whether in Sri Lanka, whether you are doing any IV iron infusions in the primary care, but in UK, it is done in the hospital setup after referral to the hematology. Thank you very much. Uh, any questions? Basically. I'm sorry, I didn't prepare for that question actually. It is not uncommon. Number one, because as I told you, these gastric bypass surgeries, they invariably come with B12 deficiency, and it's very common actually. They always get IN B12 infections once a month, usually then once in 3 months' time, every time, and it's not uncommon. Thank you. Yes, yes. For a long-term management plan, oral BTL is the plan. But if they are really going down with level, it's to do the level. If the B12 level goes down to less than 200, I suppose, so they are treated with IM, IM B12 replacement. Yes. Uh, Gastrectomy, no. Sleeve gastrectomy. I'm not that sure about that specific about the surgical part. Yeah. Uh, Thank you for the question. Uh, Actually, there is an interesting thing. If you are taking PPIs, right? So if you are taking PPIs, they will have the iron deficiency due to poor absorption, number one. So if you are having gastritis and if you start PPI, then you will have double the issue, increase the problem of poor absorption. That's another issue. So you have to weigh the balance between two. If the patient cannot tolerate oral tablets, it's the indication for IVI. That's what we mean.
You mentioned a lovely talk, Gamini. You mentioned something about not giving blood.
Oh yes,
Could you
blood transfusions have more hazardous, and I mean it is as for the last resort. It is not any indication for anemia because anemia means that although I told you like that in my clinic, IVN clinic, I have given some patients 1 unit of blood or couple of units of blood. And then at the same time, we have given the IVN infusion as well. As the anemia is so severe, according to the age, it depends on how the patient is, what the age of the patient, and what are the comorbidities, of course. If the patient is more than 56 years, and if there are comorbidities, and we can't be waiting for the own production of blood cells by the patient. So at that time, we have to give.